Yeah, if somebody could, I guess I'm.
Okay, there you go. So
Here we
there,
go. The purpose of the two cases I actually have brought, one is actually an older case, and another one is a case from March in which actually you were there, Manus, as assisting us with your expertise, and it's the purpose is about troubleshooting when you get into a situation in which equipment will not go, and then you might be forced to use atherectomy devices or other tools to try to open a bigger channel to be able to deliver equipment. In both cases, we finally had the laser atherectomy device. I will go to the first one, and then I'll talk to you about the interest of the second one, which is the older case. But the first one is the one from March. This is a 57-year-old male who was actually referred from another city after an angiography, which showed that he has already a prior ACV. He has diabetes. He's got peripheral neuropathy. He's got a sleep apnea. His symptoms have been improving with nitroglycerin. His symptoms, of course, get worse with activity, and he's getting several episodes a day. Can we go to the next slide? If I don't know how to go forward here.
yeah, just move.
Okay, so his medications, basically, he's already on actually a pretty good coverage. Aspirin 325. He's on lipid therapy. He's already on Plavix. He had a PCI of his right coronary artery in 2008, which now shows to be the problem. He's continues to be a smoker. He's got some family history of other issues. Basically, there was nothing really telling in the physical exam. He came as an unstable coronary syndrome, but with no evidence of any acuity. And this is a CKG, which shows maybe some Q waves in lead 3, but the other leads seem to be that everything seems viable. First thing we had done on this gentleman, and this is a CKG 2 years prior, which is the same. So first thing we did in order is to, we had the films from the previous institution, and we saw that he had a CTO of the right, and then this gentleman has already been bypassed. And what we wanted to make sure is that the area was viable, and we did find viability in the inferior wall with the ischemia. So we decided to set him up for the procedure, and this is his films.
Yeah, actually, I am for some reason it's a little sluggish right now. I'm just clicking on it as well. Yeah, I'm sorry. I'm sorry for that, Alex. I'm working on this. It looks like towards the end of Santiago's case, something happened with the WebEx. Okay, what we're going to do instead is I'm going to have to show it in a different way. So we'll see the films in a different way instead of the way we have so far. So excuse me for 1 second here. So the question here was that I think on terms of viability, do you always do viability for your CTOs, or do you do it once in a while?
Well, you know that is a good point and a good concern. I think you probably want to make sure that what you're having is related to the CTO, and I think if you have an area that is either not ischemic or non-viable and a scar, I'm not sure that we know that there's a benefit. So I think we need to prove it to some degree.
Sure. Now, having angina, so some people are saying, and again, this is little controversial, but some people are saying, well, if you have angina, then by default you're going to be viable. Do you kind of like this kind of line, or you don't?
Well, it's actually the most insensitive way to determine viability, and sometimes we get fooled. I think sometimes even in the presence of symptoms, we end up seeing lesions. We put a pressure wire. We don't find ischemia, and we end up not fixing them, and the patient remains with some symptoms. So I'm not sure that we can one way or another say unless we have a little bit more definitive information. I think objective protects you too. I don't like to practice defensive medicine, but I think we sometimes get forced to do it to some degree.
Sure. So again, we have a little technical difficulties here, but I guess you can see the still frame. So you have a stent, looks like an old stent in the right.
This is actually the second case, Manus. Images from the second case.
Okay, let me go back to the first one.
Yeah, maybe we've misplaced the images and we put yeah, I think we put case 1 on case 2. I really apologize. I'm having trouble here.
Okay.
This is exactly the case. The interesting case is here we actually cannulated our IMA graft as our graft of as our contralateral access, and we also and with an IMA guider, and we have a Amplatz 1 guider for the right coronary artery. And if we can replay the images, you can see a flow going from septal collaterals to the CTO of the right. So that made it for a little more complex procedure in case we had to do a retrograde approach.
Yeah, do you ever go retrograde on the Lima, or you try to avoid this just to prevent any complications?
Well, that's a good question, and my experience is not your experience, and we're basically in our infancy, and I haven't had the opportunity to have one that I need to approach in retrograde fashion. So to answer your question at this time would be no.
Yeah, and I think you're right, because the point is it's a more risky thing, so you don't want to do this unless you don't have any other option, and you really, the patient understands exactly what's going on.
So to summarize here, if you can see, we're doing injections via retrograde fashion, but we also have already a wire, and I believe this is either a pilot 50 or a pilot 200, and we have a Corsair in the middle of the right coronary artery, and the crossing of the occlusion was relatively easy, and this is not where the issues began. We actually started doing some initial angioplasties, and I don't know if we can move forward. And so we're doing angioplasties, and you can see just exiting the guider. I think we have one of those catheters, extension catheters from Vascular Solutions, the guide liners. Now we started doing some angioplasty. If we can go forward. Suddenly we took an injection in the antegrade channel, and we believe that the guide liner probably was touching the wall, and we created a severe spiral dissection into the distal RCA, which involved the ostium of the vessel, and also you can see the aortic cuff with the dissection. At that time, advancing equipment became extremely difficult. Not even the 1.25 balloons would go across. We tried several options, including advancing the guide liner further, but I think what happens when you have this type of dissections is like a hole in a cave. A whole wall comes with rocks, and I occlude the cave again. That's kind of like the analogy that I give to it. And we had no way to advance further balloons. We made a decision to perform a laser intervention. We did about 3 minutes of laser, and that allowed us to start advancing balloons again. And if you can go to the next picture, this is the picture when we created a dissection. And so we stopped doing antegrade injections, and we made sure that we didn't remove that wire by mistake, so we kept a very close eye on it. And after the laser, we were able to continue advancing balloons. If you can go next picture.
Sure. Actually, before we go on, I don't know what people think. I don't know, Santiago, also, what do you think about the little dissection, the aortocoronary dissection there? That's one of the things that one can get on when you deal with osteal lesions and you get dissection.
Yeah, I'm still trying. I mean, of course, I'm worried about it, but I'm still trying to understand the mechanism. How confident do you feel that your wire is in the true lumen and that you need? Because it seems to me like this happened after you balloon it. Perhaps you were expanding the subintimal space with a balloon instead of the true lumen, or perhaps it looks like an AL1 type of dissection. So I'm trying to understand the mechanism because I think it's important here, so you can.
Unfortunately, this case went for several images, and we have only a few images. We had done some antegrated injections priorly, and we know we are in intraluminal distally. It's until we advance that guide liner to give us support, and then do further injection that we had that dissection.
Yeah, it is one of those things where it happens and gets you off guard, and where you thought that it's going to be over very soon. It's a very simple and straightforward case, but the reality is it didn't quite happen. So you have to be careful, because when you think you won and you got distal true lumen, then you may get into unexpected problems. So.
I don't know if you have further images. Finally, after laser, actually the equipment was easier to be advanced, and we continue keeping the guide liner, but we decided not to do further injections until the end of the procedure. I'm not sure how we can go forward here.
Sure. And actually, if I can say, in previous cases, the guide liner one should not think that the guide liner alone is a safe thing, because I've seen cases where you have the guide liner in, and the contrast dissects retrograde, and actually can increase the size of your aortocoronary dissection. So all of the guide liner gets the contrast further down. You're not off the hook, because you can still dissect and cause aortocoronary dissection.
Mm-hmm. So you can go forward. This is just post-laser inflations, and I think we're about to do the final injections. I think we have positioned a stent there already.
And I think this is, it seems like you're able to deliver stents now. This is, I think, important teaching point, which, most people think that every time they see contrast in the cusp, that's an indication to stop and send the patient to surgery. And the reality, I think, in my experience, is that if you stent that, if you can seal that dissection, you're just fine. In general, that will not progress any longer as long as you can tuck it in with a stent from the coronary.
Absolutely, I agree with that, and that was the experience in this particular case. It basically sealed that dissection, and this is probably one of the final pictures. I'm not sure if we have one more, but the patient has been. I actually saw him in clinic yesterday. He's actually doing fairly well, and that. He needed the blood flow from that right coronary. His wife is very happy the way his level of activity has increased in the last couple of months.
And if I can say, what do you think about the distal vessel? I know we discussed about this, and there are different opinions about this, but there's some diffuse disease distally, but you still have TIMI3 flow. I don't know if people like to stent this or try to leave them, or what people think about that.
I think In general, I try to leave them alone. When you start trying to make an artery like this perfect, then you run into trouble. And in general, they tend to grow. And if you were to cut them in a year or two, it probably is going to be better after you establish antegrade flow. So in general, I don't muck around with this. I leave it alone.
I agree with that, and mostly in this particular scenario, you have a bifurcation, and you could complicate one of the side branches by trying to approach just the distal right, or maybe complicate both side branches. So in this particular case, I even have more of an issue trying to extend myself.
Yeah, and I think the problem is if you start standing further down, you're going to run into problems because the vessel is so small, you may dissect, and then if you dissect the bifurcation down in the PDA-PL, then it's going to be extremely hard to salvage this. You're going to lose one of the branches. So instead of doing that, what you just did is perfect. Give flow there and let it grow over time. And actually, Freddy Galassi has shown that if you leave this alone, so the vessel grows up by up to 0.5 millimeters over the next few months. So there's a good chance that this may grow in size just by getting antegrade flow to this.
We haven't seen him on follow-up, in terms of cath lab follow-up, but I actually scheduled an Lexi scan for him for the next few weeks just to do that type of follow-up, because I agree with that. In this particular case, we haven't seen it, but I have seen it in other cases in which looks this way, and you come back and you get much better imaging. So I think we had a relatively good result.
I think it was great. And I think the other point here is that this is a very small vessel, but there are other cases where the vessel looks bigger. But what happens even those bigger vessels, you put a stent, and then you come back a few months later, another stent is it's malapposed because it's just so small compared to what the diameter of the vessel becomes.
Yes. So he left some, and as I told you, I saw him yesterday, and he's doing wonderful. I guess we have the cases mixed up, but I can
That's
go.
Fine. I'll just put the film for the next one.
So this particular patient, he's in his early 60s, and this is another gentleman who was having symptoms of heart failure. And this case we did in early 2010, and there's a couple of interesting situations. We had not started our CTO program then, and this is a radial case, and this was basically an ad hoc procedure. We know that the patient had ischemia, and because we also did a stress test on him, and he was having symptoms. And what we found is that predominantly the right coronary artery was open, with the exception that they had a distal occlusion just before the bifurcation. And again, sometimes the ignorance is bliss, and we decided to do the approach at the same setting and this procedure, and we switched for a 5-French guide catheter from the radial axis. And if you want to see the case, all I can tell you is we did over 70 CNE runs. We just have a few here, but we struggled significantly getting a wire to go into across the CTO, and if you can see again, ignorance is bliss. We don't have a contralateral catheter, and this was an ad hoc procedure. So maybe some teaching point of what you should avoid doing, and thankfully sometimes God protects even the dumbest of us, and we find a way out. And so after several minutes or maybe an hour of work, we were able to get a wire distally intraluminal. And if you go forward,
what wire was this? I'm sorry. So was it? Did you have a microcatheter, or was it just a regular, no microcatheter?
We ended up using microcatheters. If I'm not mistaken, we used a fine cross in this case eventually, and there might be a picture, but I'm not sure if I actually downloaded. This is actually a balloon, and we used a balloon. And I think finally we had a Pilot 200 cross it. Either that or a Pilot 150, but we didn't use confianzas, and at that time we did not have filters available. So this is after several minutes of struggling, we finally got in. If you can go forward, so I can show you. We were not able to get a balloon across the same way, or a catheter across the same way.
I'm going to give you
and you almost can see, and we were very afraid there that we might be in a dissection plane. At that time, we also didn't have stingrays available, I think.
Get a feeling from you.
If you can go next.
I made a good.
So it looks like you have a nice. So you have the wire. Now it's better. Now the wire is located okay in the posterolateral. And is that, did you exchange the wire for a soft one that sometimes do that just to prevent any injury, or is the original Pilot 200?
You know, I've actually been very successful with the Pilot, and I feel very comfortable leaving Pilots in there. The only wires that I really get uncomfortable with are the true CTO wires, like the Miracles or like the Confianzas. Those ones make me uncomfortable, but the Pilots we've been very successful and I haven't seen a complication of a perforation with one of those as of this time. So this time we already know we are across the CTO.
Right.
Again, this is a 5-French system, and we were not sure if we were going to be able to do a laser through a 5-French system. So we actually did. The reason we decided to go with laser is because we could not cross a balloon again, and so we called the company, and in the phone they said that they were not aware of somebody had done it 5-French. So we gave it a try, and we were able to cross the laser. After that, again, the procedure became fairly easy, and we were able to angioplasty and stent it. I'm not sure if you can run those images, Manus. We have the first angioplasty position after lacing there. We usually don't even see the laser because it's only one dot, and it looks like a balloon actually. So we don't really actually take pictures of the laser. And this is a picture after the angioplasty, and I think after that we decided to stent. I actually saw him on follow-up a couple of weeks ago. I have done a recent stress test on him, a Lexi scan, and he's not ischemic in that wall, and he's doing fairly good.
Can I ask actually something, Alex, on the laser? Did you use contrast injection as well? Or did you just use the laser as is? Like, did you put any contrast? Sometimes people use the over-the-wire laser, and they put like a 30% contrast mixture through the over-the-wire port. And by doing this, as you know, it just boosts your penetrating capacity quite a bit. Of course, if you don't know where you are, not the best way to do. But if you are confident you are within the vessel and you cannot penetrate with something, there are some people advocating of using this mixture that really increases your penetrating capacity for the laser.
Okay.
I haven't particularly used it. I'm aware of that. One of the other things also can be that with penetration could be further dissection, and it might extend the length of your stenting. But I don't think that I have a problem with that. I just have not done it, so I couldn't give you much information on it. I don't have experience. And we've been very successful. I've probably done about 30 or 40 laser cases in coronaries with CTOs, and we still haven't used one in which we actually get contrast.
Perfect. That's good. You should publish this. There's not really a big laser series for CTO, so that's a great one to publish.
We're trying to get this one published because it's the only one that I know that has been done through a 5-French radial system.
Yeah, no, but even the series that you have, that's a great, because people are debating about this. Laser is having a comeback now, and this is a great use of it in these complex calcified CTOs you cannot cross.
Yeah, we'll probably review and see if we can get something. But that's actually a good point. I'll converse with my fellows about it.
It's amazing what you could do, through a 5-French radial case. The complexity, I think, is remarkable.
And as I said, I think one of the nice things and teaching points is like, I don't think this should be done ad hoc. I think when I did it, I've been to the training programs. I've had Manus come a few times here. Extremely knowledgeable interventionist, and so we've basically changed. And when I see this case, I just put my hands on my forehead and think to myself, what was I doing then?
But this is normal. Actually, to be honest, every single one, including myself, when we started doing them, and then we did the several things, and now looking at them now, we're wondering what in the world were we doing. But this is exactly the way to learn. And no matter how many times one talks about these things, it's one thing to hear about it in a lecture, and another thing to actually do it, and learning from your own experience. So I think what you said is perfectly right, because once you've done it once, you're not going to do it again. So this is the better way to evolve and learn it once and for all. And actually for other people to do as well. I'm joking, one of my first retrograde cases ended up publishing in CCI. That was a case of an LAD CTO, and actually Bill Lombardi saw it, and he called me. He's like, "What the heck are you doing?" So it's funny, what you thought was pretty cool and everything, we realized that actually you did a lot of things that made it painful unnecessarily. So again, it's I think this is exactly what people want to see, especially at the early stages, that it's good to hear about these things, but you'll do it once and then you'll learn it forever. So I think it's very useful for everyone on the call.
But
so Lilihai said one day that good judgment comes from experience, and experience comes from bad judgment. So it's you need to go through these stages. I think all of us to get better at this. It's just the nature of the game.
No.
I do think this is a tool, laser. I'm a big supporter of laser. I've been using it mostly in the periphery, but I think as an atherectomy tool is probably. I always get uncomfortable when people talk about maybe we should do some rotoblader. I just feel that doing roto through an area that has been dissected. I think I've heard Bill Lombardi and Grantham talk about it, and they feel comfortable. It's just, to me, it's still not at that comfort level in which I would feel that I can go and do a rotoblader in a setting that I know for sure has some degree of dissection.
And the other downside of rotablator is that you have to pull the wire back.
Exactly.
So, and then if you cannot get your wire back up there, then you just lost your position and you gain nothing. So I think most of us agree that this is the last resort. If nothing else works, then you pull the wire in exchange for rotablator, but rotafloppy wire. But otherwise, I completely agree with you. What you did, do a laser or do balloons or tornus or something like that is better than giving up your wire position.
No. She does.
That's what I had to show you.
She'll be his sales rep.
I hope it has. I hope help us to some degree. I think we're moving in the right direction to make this program, at least our program, more amenable to this type of procedures. I see our techs a little bit more happy, comfortable when we're working on those type of procedures.
Well, and I must say, your lab, I've been to many labs, but your cath lab is one of the most efficient labs I've ever seen. The staff is great, turning the rooms very, very fast. They're very excited about it, and you guys have clearly an excellent CTO program, as does Santiago. So I think you're on your way to great successes here. So thank you so much for showing those cases. I don't know, Santiago, if you have any other comments for the participants or for Alex.
No, Manos. Thank you for having me, and actually thank you for the support of my cath lab staff. I mean, in this case, that's the critical part. You need to be supported by good people. Otherwise, it's impossible to have a successful program. So.
You're absolutely right. So I would like to thank both of you again. And again, to remind everyone, this was Dr. Santiago Garcia from University of Minneapolis, of Minnesota, and the Minneapolis VA Medical Center, and Dr. Alex Suarez from Texas Tech in Lubbock, Texas. Thank you so much for great presentations. Thanks again to our sponsors, Terumo and Abbott Vascular, for allowing us to have this webcast. And thanks to all the participants for being in this. We will let you know once the next one is scheduled in the next couple of months or so. Thank you again so much, and have everyone a great day.
Thank you, Manos, and I appreciate your support.
Thank you.
Thank you, Manos. Bye.